Good afternoon, everyone, and on behalf of the Friends of the Village Library of Cooperstown, welcome to the first of the Sunday Speaker Series for 2021-2022 with Richard Loftus and his presentation, Long COVID Syndrome and Other Post-COVID Complications. My name is Leanne Hirabayashi, and I'll be co-moderating this session with Antoinette Kuzminski. Thank you all for joining us. Let me go over a few items related to logistics and format for this session. There will be a couple brief messages from the host and sponsor, after which my co-moderator, Antoinette Kuzminski, will introduce our speaker who will make his presentation. Then we'll have a question and answer session, which will be handled by my co-moderator, Antoinette. For attendees, and it looks like we're up to about 15 of you, at the bottom of your Zoom window, you will see several icons in a bar similar to what I'm showing here. Please note that chat is disabled and we are not going to be using the raise hand feature, just that Q&A tool. If you have a question, click on the Q&A icon and send it in at any time. Antoinette will be monitoring that tool and asking questions on your behalf. Please note that we may not be able to get to everyone's questions, and we appreciate your understanding on that. Finally, the programs in the Sunday Speaker Series are being recorded, and a link to each recording will be made available on the Friends of the Village Library webpage. The Friends of the Village Library works closely with the library to sponsor educational and entertaining programs for the Cooperstown community. The annual Sunday Speaker Series is one way the group fulfills its mission. Last year's programs featured a diverse group of speakers that included author Gretchen Soren on her book Driving While Black, Tim Johnson on establishing rural broadband in our area, and Chris Rossi and collector Gary Casanelli on the art of keep herring. This fall, to avoid gatherings in small spaces, the first three programs will be presented on Zoom. Later in the season, Friends of the Village Library hopes to offer its programs both in person in the Village Hall and recorded for posting to its YouTube channel. The League of Women Voters of the Cooperstown area is grateful for this opportunity to sponsor the Friends of the Village Library Sunday Speaker Series with its goal of providing educational programming to the community, serving the people of the Cooperstown area, including the village of Cooperstown, the towns of Otsego, Middlefield, Springfield, and Hartwick, and surrounding towns in northern Otsego County. The League urges everyone to get out and vote in this big election year for county and town offices. There have been a number of local elections decided by 1 or 2 votes, so your ballot really counts. And we'd like to take this opportunity to point out a couple online resources for the upcoming election. The Cooperstown League's website, lwvcooperstownarea.org, has information about key dates and resources for planning to vote. And go to vote411.org to get a guide for the November election with issue-related questions to and answers from candidates, as well as information about those 5 ballot proposals from the state. So now I'm going to end my slideshow and stop sharing my screen. And now my co-moderator, Antoinette Kuzminski, will introduce our speaker.
Thank you, Leanne. It's a privilege and a delight to welcome Dr. Loftus both to Cooperstown, Friends of the Village Library, and also to Bassett Hospital. So following graduation from Yale University, Dr. Loftus received his MD degree and postgraduate training at University of California in San Francisco. He later joined Eisenhower Medical Center, a teaching hospital affiliate of the University of Southern California, as Associate Programs Director, supported by a fellowship in medical education. In addition to his patient care and teaching responsibilities, Dr. Loftus has been active in both bench and clinical research in diverse fields, including HIV, community medicine, care of homeless populations, and humanism in the practice of medicine. There are so many awards and publications on his CV that I just finally stopped scrolling. So in short, Dr. Loftus is an internist's internist. Welcome, and it's yours now.
Oh, Tanette, you're making me blush. I'm glad it's a little dark for my lighting so you can't see how much I'm blushing. So thank you for that lovely introduction. So hopefully you guys can see my slides okay, yeah?
Yeah.
All right, great. So the title of this talk is Post-COVID Complications and Long COVID Syndrome. And we're going to talk a little bit about I think what has been an ugly stepchild topic, which is that, we not only have, of course, the problem of the acute COVID infection and, the complications people get while they're battling it, but I think what's often not talked about is the question as to these long haulers and people who have different kinds of medical complications after they've gotten through their COVID. And while you would expect that a lot of these are in folks who were on the sicker side and maybe needed to be hospitalized, we even do see some of these post-COVID conditions in people who had pretty mild experiences, and sometimes even in people who didn't have any symptoms whatsoever. And we're going to talk about that when I show some of the slides. What we'll do now is, here we go. So I just wanted to give some disclosures. I have been a paid principal investigator for Cytokine and for Merck Sharp and Dome. I don't really talk about their products directly, but they are doing research on therapies that could be used in COVID. So I wanted to make sure I mentioned that. I also wanted to explain that while I'm a happy member of the medical staff at Bassett and a happy internist at Prime Care on the main campus, I don't represent Bassett on the subjects here today. These comments are purely my own, and I just represent my own opinion. I don't represent Bassett on anything, and if you want to know what they think about something, you'll have to ask them. So this public talk, like all of my public lectures, are dedicated to all the women activists that I worked with throughout the years. In particular, for the COVID talk, I wanted to give a shout out to Diana Barrett of Survivor Corps, my pen pal Kirsten Urquiza, who started Marked by COVID, Akshita Sadula, who's my colleague at the Right to Health Action, and Lorraine Lopez, who's one of my nurse buddies back at Eisenhower, who was with me shoulder to shoulder as we got through the first couple of surges of COVID in the hospital there. My takeaway point is kind of the 37,000-foot view, which is COVID-19 is not an event, it is an era. And the picture that I'm showing there is from C.S. Lewis's novel, Voyage of the Dawn Treader. So in the real world, of course, we know that the world doesn't have an end point, it's a sphere. But in C.S. Lewis's fictional Narnia world, Narnia is actually a disc. So there is an end to the world and the characters travel to it. So I thought that was a nice visual metaphor for the notion that as much as we'd like to say that COVID is going to be an event with a beginning, middle, and end, I'm afraid it's not going to be so clean cut. We had hoped that we would achieve something like herd immunity with the original strain that was circulating, and then Delta came along last summer and sort of ruined our party. So here we are, still dealing with everything. It is a truism in the history of medicine that pandemics usually have fairly clean-cut starting points, but when they end is very fuzzy. And so I think the same will be true with COVID. I think that it's going to be affecting our thinking in a lot of areas of our culture for some time to come. That's food for thought. And depending on how much time we have at the end for questions, we can talk about that. There have been some interesting papers about the last emergence of an epidemic, coronavirus, and I'm not talking about SARS or MERS, which were 20th century phenomenon, but actually the Russian flu of 1890, which we now think in retrospect may have actually been a coronavirus. With that said, I wanted to actually highlight one of the more recent studies that came out. And this was a headline from one of the Philadelphia papers on long COVID, emphasizing that about half of the survivors in this meta-analysis actually had lingering problems. It was a study of studies, so 57 different medical studies internationally, and I'll show you some of where the countries were that the studies were done in a later slide. But they were looking at patients and how long they had lingering symptoms or medical complications 6 months or even beyond their original COVID infection. So initial reports describe some of the immediate lingering symptoms. And by lingering, most people mean more than 4 weeks after the first diagnosis of the COVID infection. So things like fever, shortness of breath, mood disorders, including depression, muscle pain, and damage to the heart, lungs, and the blood vessel systems. But this meta-analysis also called attention to some of the other important findings, that 20% of survivors were having decreased mobility in the wake of surviving COVID. About a quarter of them described problems with concentration and their mental function. Nearly a third of them had developed generalized anxiety. Many had difficulty breathing, chest pain and palpitations, but there were other symptoms, hair loss, skin issues, even digestive problems that were also reported. So I'll show some reasons why in a later slide, but unlike influenza, which is really a disease of the respiratory system, SARS-CoV-2, the virus that causes COVID-19, can get into blood vessels and can get into a lot of different vital organs. So it is truly a multi-system disease. And I think that's one of the themes I wanted to bring up in my remarks. So scientists are studying at least 4 urgent questions about long COVID, as we call it. How many people get long COVID? Who's most at risk? What is the underlying biology of it? What is the relationship between long COVID manifestations and other post-infection syndromes? And what can be done to help people who are dealing with this complication? And there's a number of different terms or definitions for what we're talking about. Tony Fauci in February of this year introduced a term, post-acute sequelae of SARS-CoV-2, which turns into the acronym PASC. So we see that now in a lot of the papers on complications of COVID. But I think that's just a jargony version of what lay people might just call post-COVID complications or post-COVID conditions, which is what CDC tends to use in reference to it. There's also this thing called the long COVID or long haul COVID syndrome, which is something akin to a chronic fatigue syndrome with brain fog or decreased concentration and mental functioning, as well as diffuse muscle pains and other kinds of chronic ill health sorts of symptoms. That seems to be a discrete entity and different from some of the organ injury syndromes we see from COVID. And then there are people in medicine who feel like they've seen some of these complications in people with other conditions, and that we already have names for some of this. There's something called the post-intensive care syndrome, which is just what we see in people who've recovered from critical illness and sometimes are disabled after their stay in the ICU from whatever reason. Post-viral syndrome, which is the term for some of these chronic fatigue presentations. There's myalgic encephalomyelitis or chronic fatigue syndrome per se, whose etiology has never been clearly defined, but people suspected it was produced by a virus or a variety of viruses. And then there are what are called dysautonomias, including a specific one called postural orthostatic tachycardia syndrome, or POTS. There are examples of people who survived COVID who then are diagnosed with POTS, which is a condition that involves palpitations and chronic fatigue and problems with regulating their blood pressure. So, I had mentioned before my talk that I didn't want to get into too much of the technicalities because I'm not assuming any previous medical knowledge by the audience. So we'll try not to get too caught up in the jargon and just kind of hit the broad ideas here today. Oh, and there was a final entity, something called mast cell activation syndrome, which does seem to have a relationship with people who get more severe forms of COVID. I think the point is just that some medical scientists feel like we've seen some of these complications by another name with other viruses or previously in our history. So finally this month, the WHO issued a formal case definition for post-COVID-19 condition. These are pretty common sense, but what they said is you have to have a history of probable or confirmed infection with SARS-CoV-2. Usually 3 months from the onset of COVID-19, you're still symptomatic. Symptoms have been going on for at least a couple of months with an impact on everyday functioning, including symptoms like fatigue, shortness of breath, or cognitive dysfunction or problems with thinking. And you may notice, you may say it's a little weird here. They're saying symptoms last for at least 2 months, but they're saying this condition has an onset 3 months from the COVID infection. And really, I think what this is pointing to is that sometimes we have people who may not have even really realized that they had COVID-19 because their symptoms were so mild or even lacking. but then they wind up with these weird physical symptoms sometime down the road. And so that absolutely is a phenomenon we see where people may have little to no symptoms during the actual COVID, and then a month or two out, they're starting to get these other strange symptoms emerging that affect their function. And the WHO case definition insists that these symptomatic complaints can only be called post-COVID-19 condition if they can't be explained by an alternative diagnosis. So there are some problems with the WHO case definition that have been pointed out by people who've been working in COVID, including Al Ali, who is one of the researchers whose papers I'm going to be presenting a little bit later in this talk. Part of it is that they have only based their case definition on symptoms. It ignores many forms of the disease, forms of disease that are caused by COVID-19 that we feel pretty confident is related to the SARS-CoV-2 infection, like new diabetes diagnoses, certainly heart diseases, kidney diseases, other conditions of organ injury seem to be ignored by this. And it makes long COVID a diagnosis of exclusion, which sort of marginalizes this condition. When we had patients last year in the summer who were showing up to their doctors complaining that they still felt unwell months out from their original COVID infection, they had a hard time getting people to believe them that they were truly sick. People kept telling them there was nothing wrong with them. And of course, they did have a condition, and this is a real phenomenon. And one of the original version of this Grand Rounds made the point to the medical folks I was presenting to that we should listen to our patients and believe them. And so I think that point still stands. So I do think this WHO case definition doesn't help us that much. I'm hoping when CDC finally gets around to releasing their case definition, they'll do a little bit more of a robust job of things, because we do need some kind of formal case definition. But as you'll see in a moment, what we're talking about when we talk about post-COVID complications is a very diverse array of medical conditions. So speaking to that, here's a nice diagram that explains what I was saying earlier, which is that this is a virus that gets into many different organ systems. So the receptor that the virus uses is a receptor called ACE2, and it is found in a variety of organs. And so I'm just going to highlight, of course, the lung. And of course, most people think of COVID-19 as being a respiratory infection. There's coughing, there's shortness of breath. But the virus can also infect tissues in places like the heart, the brain, the kidney, the pancreas. So there's a whole host, not to mention you may see there's some reproductive organs in there as well, and even the intestinal organs, a few of them. So this virus can get into blood vessels, and blood vessels go everywhere. So a lot of the major organs are potentially affected by this virus. And I think that makes the point that we need to be wary of a variety of complications because of that. It's not just the lungs, and this is not just flu. So going along with this, there's a few different ways that this virus can mess up our physiology. So if you look at this cartoon, you can see on the far left that the virus is binding to the ACE2 receptor, as well as a co-receptor that's mentioned there. That's the little red rectangle next to the virus, and that's the transmembrane protease. So there's two enzymes that the virus uses to latch on to human cells and get inside them. So you can get a direct toxic effect to the tissue just because the virus is infecting the cells and hurting them that way. But we also see that the virus, because it uses a receptor that is part of a hormone system called the Renin, Angiotensin, Aldosterone system, this is a system that your body uses to keep your blood pressure in balance and make sure all your organs are getting oxygenated blood. So if those hormones are dysregulated, you're going to have problems regulating your whole cardiovascular system. In addition, we can see that the cells that line our blood vessels can get damaged. That's the third way that damage can happen, and that can lead to the formation of blood clots in our blood vessels, and you can see complications like strokes or pulmonary emboli. And then finally, the fourth way that this virus can mess us up is that it looks like it does some weird things to our immune system. We noticed right away that when people get infected by SARS-CoV-2, that we see that their lymphocytes, especially their T lymphocytes, which is a type of immune cell, dip low. And we also, from other studies, can tell that the interferon system, which is the body's natural antiviral system, gets messed up by the virus. In the test tube, SARS-CoV-2, the virus that causes COVID-19, is exquisitely sensitive to interferons. So it makes sense to me that it would find some way to turn the interferon system offline in order to have free rein in the body. In fact, there's even some belief that some of the long COVID syndrome that we see may be the result of other viruses waking up because SARS-CoV-2 shut off our natural interferon system as part of its dirty work. And that causes other problems with the body and other viruses that may have been latent up until that point. So the point here is just that this virus has a few different ways that it can mess up our bodies, and that can produce the long-term complications. And that's illustrated here. If you look at the far left of this cartoon, you can see the virus infects the body, and then you see this big spike of virus levels. You can see a lot of virus in the respiratory tract and in the nasal area and the throat. And then those virus levels, by the time you're a month out, even with the most sick people, you're not seeing a lot of virus around any longer. But you are seeing all of these physical manifestations, which can include things like fatigue and muscle weakness. You can see chronic shortness of breath and the persistent need for oxygen. You can see a host of problems with the brain and the nervous system, damage to nerves, as well as problems with the central nervous system itself. You can see chest pain, different kinds of heart rhythm problems, clotting complications in the blood vessels, kidney damage, hair loss, just a variety of things. And so that comprises all these different entities that we lump together when we talk about post-COVID conditions. So before I go forward, are there any questions at this point that I can answer to clarify where we are at?
Well, there was one question, Richard. So the definition of survivor, I assume anybody in whom antibodies are present who has not been vaccinated, or how do you recognize those asymptomatic people who later on seem to have actually had a post-COVID problem?
Right, that's a good point. And we are going to talk about a study where a lot of the patients were identified as having had SARS-CoV-2 only because they got tested for other reasons and not because they had physical symptoms themselves. But you're right, especially in the early days of the pandemic, there were a lot of folks who could not get a test. And so they suspected they had COVID-19, but they weren't sick enough maybe to get into a medical facility where they would get an official test. We do now have a commercially available test that looks at the T cells to look at whether the patient actually saw SARS-CoV-2 virus. But as you saw in the WHO case definition, even a strong suspicion based on the history and circumstances could lead to a de facto declaration of likely infection with SARS-CoV-2, even if you don't have blood tests that prove that. But you can use an antibody test. Depending on which antibodies you're looking at, and how far out from the original infection it was, those tests can be more or less reliable. The antibody tests, in order to confirm that you actually were infected with virus and weren't just getting immunity from a vaccine, look for antibodies to the N protein, the nucleoprotein of the virus.
I see.
But the vaccines only have spike protein. So if you only have antibodies against spike and you don't have any against the N protein, then that suggests immunity from a vaccine rather than immunity from the virus itself. But there is also a test that looks not at antibodies, but at the T cells and looks at their memory and can also make an inference as to whether this person actually already saw SARS-CoV-2. So there are some tests that are available to do that. But it's absolutely true that in some cases, we'll just have to say that somebody was presumptively infected because of their characteristic symptoms, because we won't be able to prove it. The tests aren't, sensitive enough once you're many, many months out necessarily, because the antibody levels will wane.
So the term survivor is a very broad term then.
That's right. And it's often based on clinical suspicion or clinical grounds rather than, a blood test that proves it.
Okay.
Yeah. So the CDC describes post-COVID conditions as a wide range of new, returning, or ongoing health problems people can experience more than 4 weeks after first being infected with a virus that causes COVID-19. Even people who did not have symptoms when they were infected can have post-COVID conditions, as I was mentioning. And these conditions can have different types and combinations of health problems for different lengths of time. And it is true that the longer you follow a group of patients with lingering symptoms, it does tend to go down over time. So it does look like a lot of people will eventually recover. For example, people who lose taste and smell may take the better part of a year to recover those abilities, but it does look like many of them will recover. So not all of these problems wind up looking permanent, but there are some people who even at 12 months are still not feeling back to normal. So the CDC notes at least 4 categories of post-COVID conditions. There's what we've called the long COVID syndrome, which is this chronic fatigue-like condition with fatigue, muscle pains, cognitive changes in the brain. There are also multi-organ effects, which include specific injuries to different organs like the lungs or the heart, but also something called multi-system inflammatory syndrome, which we'll talk about in a moment, that's mostly seen in children. There's also just the effects of being critically ill and being hospitalized, as I mentioned. We often see debility in people who are in the ICU for whatever reason. And those patients can take time to recover no matter what really landed them in the ICU in the first place. And so that's your post-intensive care syndrome. And of course, a lot of patients wind up traumatized from some of the stress of their experience of facing a life and death infection. And so post-traumatic stress disorder is common in survivors. And we'll see that in the international data when I present that in a moment. So post-COVID conditions or PASC currently have no standardized definitions. There was a forum back in June where one of the experts described it as abnormal symptoms or function tests or imaging. And John Brooks of CDC said that guidelines are impossible at the present because we have an insufficient evidence base. Although, the fact that I was able to update this talk in just a couple of months with a 57 study meta-analysis tells you there's a lot of research ongoing about the complications of COVID. So we'll have more information and better information really every passing week. But CDC is planning to develop some guidance, and they've got multidisciplinary committees working on this right now. And there's some standardized case definitions that I hope will be forthcoming soon. But if I were to try to Venn diagram this out, this looks a little complicated, and I guess it kind of is, but you can see the big umbrella there is the post-acute sequelae of COVID, or PASC, which covers a bunch of stuff, including this long COVID chronic fatigue flavored condition that some people have. Then you have the MISC, which is this inflammatory autoimmune driven condition. You also see the post-hospital complications that are common to most people who survive critical illness, or common to some anyway, of a lot of survivors of critical illness. And then you can see a bunch of different specific organ injury syndromes, including fibrosis of the lungs, problems with the brain, problems with damage to the heart, with the kidneys, with the intestinal tract, etc. So CDC, again, describes a variety of symptoms in long COVID. So fatigue is the hallmark, and difficulty thinking or concentrating, which is sometimes referred to as brain fog. Chronic headaches, persistent loss of smell or taste, which is a very characteristic symptom of COVID-19 versus other respiratory viruses. Dizziness on standing or heart palpitations, chest pain, difficulty breathing or chronic shortness of breath, chronic dry cough, joint or muscle pains, depression or anxiety, fever, and symptoms that get worse after a moderate physical or mental activity. There's also multiple specific organ injury syndromes, and honestly, each one of these organs could be its own hour-long lecture just on post-COVID complications. But in the lungs, we see pulmonary fibrosis, which just means that the lung fills up with like a scar tissue, which makes it hard for it to exchange oxygen. In one study from Italy, looking at mostly patients who had been in the hospital with COVID, so they were pretty sick at 4 months out, their ability to diffuse oxygen across their lungs had been severely impaired in 1 out of 7 of the patients. And when they had them perform some really simple, like get out of the bed and stand on one leg kinds of challenges, many of them were not able to do that. In fact, the majority of patients could not handle simple balance exercises or a 2-minute walk test. For cardiac complications, we can see damage similar to what you'd see in a heart attack, but also the kinds of damage you would see from viruses hurting the heart directly. You can see problems with the heart pumping blood, as well as stiffness of the heart that makes it tough for it to fill with blood, even if it pumps reasonably. You can see a bunch of potentially very problematic and sometimes lethal heart rhythm problems and chronic chest pain. And then in the brain, one of the more famous studies was from the UK Biobank, which was a large study that had been following people and scanning their brains for years. And so they already had records of the brain scans of patients prior to them ever contracting COVID-19. And so they looked at almost 400 patients who had survived COVID-19, only 4% who'd been sick enough to wind up in the hospital. And what they found was that to a person, these post-COVID survivors showed loss of the gray matter in particular sections of the brain that have to do in part with executive function and memory, among other things. So that was a study that in particular got a lot of attention in the early summer of this year. And I could go on looking at the complications in some of the other organ systems too, but that's just kind of the broad themes there. So MISC is this multi-inflammatory syndrome caused by COVID-19. It's mostly a pediatric complication. We see it in about almost 4 out of 10,000 pediatric cases. And it can involve signs like fevers and critical illness in more than 2 organ systems with inflammatory markers, and usually either a positive COVID test in the recent past or a history of having been in a household where the adults all had COVID-19. And it resembles a condition called Kawasaki disease, although it's different from that. In both Kawasaki and in this MISC, we treat them with a cocktail of immunoglobulins or antibodies that are non-specific, which seems to lower the activity of neutrophils, which is a kind of immune cell that gets out of control in this condition and causes damage to the body's own tissues. This condition also looks a bit like toxic shock syndrome. It has been seen in a few younger adults, and by younger I mean adults under 50, but I think it's amounted to maybe 24 total reported cases in adults. So this is really more a complication we see in kids. And then, as I mentioned, anytime you have patients who've been critically sick in the ICU, you can see lingering complications afterwards, no matter what landed them in the ICU. And that is just as true with COVID-19. When we talk about post-ICU problems, you can see that about 1/3 of patients who've been on ventilators wind up with ICU-related muscle weakness, 50% of patients who survive sepsis who are in the ICU. You can see a wide range of them have cognitive dysfunction, sleep problems, mood problems, and a minority of them are able to return to work in the first year. So this is true of all patients who survive a prolonged stay in the ICU, meaning more than a week in the ICU. And this would be expected to probably be as true for COVID-19 survivors. In fact, many of the clinics that were first established to look at post-COVID complications were established with these post-ICU patients in mind because they figured this is a critical illness. It put some people in the ICU. We expect some of them will have complications from being in the ICU afterwards. Let's have a clinic ready to help them with their recovery. And then they started seeing some of these young adults in their 30s, 40s, and 50s who were never critically sick, maybe didn't even need to go to the urgent care with their COVID-19, but then wound up with this chronic fatigue syndrome with muscle pains and brain fog. And they just did not know to expect these people. And they were a whole other group that have had to seek care for post-COVID complications. So as I have shown you, there's a variety of different conditions that are all under this umbrella of post-COVID conditions. Long COVID affects a large number of COVID-19 survivors. Maybe I'll pause before I launch into the Fair Health study. Are there any other new questions that I can answer to make sure everybody's tracking along okay here?
There was one person who asked about duration of symptoms, particularly taste and smell, but I believe you've answered that question. Okay. But I do just want to clarify for my own purposes. So the multiple specific organ syndromes and the MIS-C are both, there is no latency period at all. Those are both evident when the person is sick with the initial illness. They're not something that bubbles up weeks after they've had an asymptomatic infection, or
Well,
other?
MISC is something that we see weeks after the original infection. In fact, typically the kids have such a mild infection, they weren't even tested. And we sometimes have to infer that they had COVID-19 because they were in a household of other sick people. If you test them, you will find antibodies against SARS-CoV-2. So you can show that they did indeed have the virus, but they will show up critically sick weeks after they presumably had their original infection. In many cases, you can time it, based on the circumstances, and they may show up, 2 months out from when they likely had the actual infection. So it is truly in the wake of the disease. But you're right, for a lot of the organ injury patients, that is something that is appreciated while they're in the middle of their acute COVID. Although that said, we have had some patients here in Bassett in the registry who did not seem to have too bad of a time with their actual COVID, but then show up with a severe heart failure syndrome several months out from their original presumed COVID infection. So some of these things do show up later. In fact, this study I'm about to launch into here speaks to that very thing.
And the multiple specific organ syndromes, the MIS-C, is that what used to be called cytokine storm?
No, that is different from cytokine storm. Cytokine storm, you're right, is what happens during acute critical COVID. And it's what we think explains, the dysregulated immune state that lands people on the ventilator. There are phases to how the body responds to COVID. That first week to 2 weeks is really when the virus is predominant. But then after the virus levels subside, you see an inflammatory phase where the immune system is affected, probably by some of the injury that I mentioned the virus does to the immune system. And then the immune system goes out of whack, and that's that inflammatory response that causes the pneumonia, that causes the need for oxygen, and sometimes the need to go on a ventilator. So that's the cytokine storm, and that's critical acute COVID. But MISC is an autoimmune phenomenon that shows up weeks to months after the original COVID infection.
Okay.
Yeah. So the Fair Health study came out in June, and it was vast. This was an American study that looked at 34 billion healthcare claims. So they were looking at patients with private insurance or Medicare Advantage plans, and they had 2 million almost acute COVID cases in the registry from February through December. So this was all cases starting in February of 2020. And they looked at new diagnoses of medical conditions 30 days or beyond the date of their SARS-CoV-2 positive test result. So what they found, and this was what made the headlines, was that 23% of patients who had survived acute COVID had at least one new post-COVID medical condition diagnosed in the year following their infection. So the key was that post-COVID conditions were found in 50% of those who had severe COVID-19, but even 19% of those who were asymptomatic, no symptoms whatsoever, were having new medical events and diagnoses in the year after their infection. So how did these people come to attention? These are the folks who maybe had a known sick COVID patient in their household and thought they should probably go get tested, and went to their primary care and got a COVID test and found out that, lo and behold, they too had COVID, but maybe they felt fine. And this is important because a lot of the studies that I'm going to be presenting today are looking at people who wound up in the hospital with COVID, people who were very obviously severely sick. But there's many, many, many more people who had pretty mild cases of COVID. And I think what the point I'm making here is, even if you have mild COVID, it's no guarantee that you won't wind up with some kind of complication to your body as a result of the COVID infection. So what's I think very interesting about this Fair Health study is that if you look at the distribution of the ages of the people in the study, you can see that it's a younger group. I mean, it's really people in their 50s or younger predominantly. It's got a very tiny minority of 70 and over, which is our group that really gets most severely sick with COVID, and a pretty modest amount of people in their 60s. So this study is looking at, younger adults and presumably people who did not have too severe of a COVID just based on their age. In fact, 12% of the patients were pediatric. And so it's a young group of patients. It's mostly an outpatient group. You can see that those who were formally diagnosed with COVID skewed slightly higher for women versus men. Does this mean that more women get COVID than men do? No, I'm pretty sure it's an equal opportunity, gender neutral, lethal virus that wants to kill all of us regardless of our sex. I think what this is women are probably a little more likely to take themselves to the doctor and get an official test that designates them as being positive for COVID, and the guys maybe just sort of lump it along at home. If you look at the distribution of severity of COVID in the study, there's 4 categories, and you can see 55% of the patients complained of no symptoms whatsoever in association with their COVID diagnosis. 40% were symptomatic but not sick enough to be in the hospital, and 5% were COVID sick enough to be hospitalized. You can also see that 1% of the patients just had loss of taste or smell as the reason why they came to medical attention and got tested at all, since that's a pretty characteristic symptom for COVID-19. And they probably thought, well, this is weird. I probably should go get tested by my doctor. And so they did. But I do think it's striking that when you define the population, not by physical symptoms of respiratory illness, but by who has a positive test, a whole heck of a lot of folks who had COVID-19 by their virus test did not really have a lot of physical symptoms. So, that might lead you to decide that we have nothing to worry about because, hey, they didn't even know they were sick, no problem. And that's kind of the point of this study is even the folks who had no symptoms whatsoever during COVID still showed up at their doctors an awful lot more than normal afterwards with new problems. So when you look at all the patients in the study, 23% of them had some kind of new medical diagnosis show up in the year after their COVID. That was 20% of those with no symptoms, or almost 19%. 27% of those who had symptoms, but not symptoms bad enough to land in the hospital. And of course, half of the patients who were sick enough to be in the hospital showed up at their doctors in the year afterwards with some kind of new medical diagnosis. Interestingly enough, those who only complained of loss or taste or smell didn't have a lot of complications in the wake of their COVID diagnosis. Not sure why that is, but when you look at the distribution of the kinds of symptoms people were describing, the most common post-COVID complaint was pain in the muscles, nerves, or joints. So that was the number one, and that was seen in 5% of the patients. But you can see that the other top 5 problems include breathing difficulties, which is not a shocker. We kind of expect that. But then we see high lipid levels, which is meaning high cholesterol, and high blood pressure. So the pain, the breathing difficulties, and the fatigue, sure, those sound like long COVID to me. But I think what was surprising was how many patients wound up with new diagnoses of metabolic problems. And this is a theme that kind of came out in this study and has now gotten more and more attention, is that we're seeing problems with high blood sugar, high blood pressure, and high cholesterol in these patients. So we're seeing kind of heart disease related risk factors spike up after surviving COVID-19. The next most common symptoms were anxiety, intestinal issues, skin issues, again, high levels of metabolic markers like blood sugar and cholesterol, and abnormal heart results. And each of these was reported by around 2% of the survivors. And again, these metabolic issues, I think, to me, are striking. And then finally, rounding out the top 15 diagnoses were migraine or other chronic headaches, reflux problems, sleep problems, depressed mood, and then a variety of abnormal organ test results. When you look at the patients who were sick enough to be hospitalized with their COVID versus those who were asymptomatic, there was a 46-fold increased risk of death in the year after surviving COVID for those who were hospitalized versus those who were not hospitalized. Now, since this study really just analyzed a data set of 2 million patients, all of whom tested positive for SARS-CoV-2, we're not comparing these people with SARS-CoV-2 negative healthy controls. So we're only comparing positive people to other positive people. But when you look at those who were sick enough to be in the hospital, they had almost a 50-fold increased risk of death compared to the ones whose COVID was pretty mild. So I think that tells you again that if you had a pretty severe COVID case, you probably got some pretty significant injury to your systems that would raise the risk of lethal complications, even if you survive the acute COVID itself. So there are some important caveats with this fair health study. The pros are it's a gymongous study. It's examined a range of COVID severities. It's really the first time we got insight into how many of our COVID-19 positive patients actually had no symptoms besides a positive virus test. But it looked at a broad range of ages, not just the elderly, not just the hospital patients, and gender differences were analyzed. Some of the big cons, in my mind, there was a bafflingly, absent analysis of complications by race and ethnicity. We know that patients in minority communities are at higher risk of complications from COVID, and why that wasn't spoken to in the report's analysis, I just find unexplainable. I actually messaged the authors to ask them why that wasn't included, because it seems like a conspicuous absence. This analysis was reviewed by a medical reviewer, but it did not have a formal peer review before it was issued. It did not look at when the symptoms were reported. Was everybody coming into their doctors 2 months after their COVID, or was it 12 months out? So it didn't really describe when the symptoms were showing up like some of the other later studies do. And it didn't characterize how long these symptoms were lasting or whether people got better from them if they waited long enough. Some other cons were that it excluded folks with pre-existing conditions, including cancers, HIV, and chronic kidney or liver disease. And it only included private insurance or Medicare Advantage claims. And since the impact of COVID is worse in less resource populations, some of the prevalences may be underestimates. Also, some of the conditions don't really have diagnostic codes, which is where they got their data. So for example, when we put diagnostic codes in for the conditions our patients have at the visit, there isn't a code for brain fog. And so if that's what you're describing that they have, you may put it under some other diagnostic code and it may be kind of diluted out. So some of the problems people complain of don't really have clean-cut codes that let us track those symptoms. So that may give a bit of a distorted picture. It also didn't compare COVID outcomes with non-COVID patients. But what would be the potential implications of this study locally? And so this is something that I presented in my original grand rounds back in June, just looking at the 5 counties in the immediate catchment area of Bassett Health. You can see that there were at that time 16,000 reported cases or a little bit more. And so we'd estimate roughly, just back of the envelope math, that we might see about 3,700 people with different kinds of post-COVID complications. And then those numbers, of course, have only gone up since then. Maybe I'll pause there before I go into the VA study. Are there any questions yet on any of that?
Well, I'd just like to inform an audience member that if you wish to ask a question, please put it in the, type it in the under Q&A. We're not participating with the hand raising. There is a former neurologist who is asking about the critical illness neuropathy. Do we know whether that is in fact due to muscle weakness, or is it neurogenic in origin? Has that issue been studied?
As far as what we see in COVID, I don't think we know the answer, but I can tell you that we see a lot of peripheral neuropathies in people who did not have critical COVID. So you can see a lot of folks who had very mild infections that didn't even go to an urgent care, who then complained of neuropathies some weeks to months after surviving the infection. And that's, I know of one case in someone who got COVID after vaccination, who still got a complication of neuropathy. So we do see that even in the mild COVID. So there is something specific about damage to the nerves that's quite aside from the critical illness kinds of neuropathies that we see in critical ill patients.
Boy, they.
Yeah, so I'm going to run through the rest of this on the quicker side in respect for time. So there was a big study at the VA that looked at 74,000 COVID-19 positive patients and also compared them importantly to the non-COVID peers who did not have infection. And they looked at them over 6 months, starting 30 days from the COVID infection. And they found that those who had survived COVID-19 had a higher risk of death with a hazard ratio of 1.59. So 60% greater likelihood of dying, and a much higher risk of needing outpatient care, including new diagnoses for pain relievers, antidepressants, anxiety medicines, and as I pointed out before, intriguingly, medicines for high blood pressure or high blood sugar, which they had not needed up until that point, which again suggests we see metabolic disturbances. So this past week, there was this 57 study meta-analysis that was published by a group at Pennsylvania. This was Patty Santongo's group. And what they showed was that 54% of survivors showed some kind of post-COVID complication 6 months out or longer. And so the studies came from a variety of countries. They looked at 2,100 studies total, but only 57 met their entry criteria for analysis of sufficient quality. The mean age of the survivors of these 57 studies was age 54 years. 56% were male and 79% were hospitalized during acute COVID-19. So most of these studies were looking at hospitalized patients. They were looking at the sicker patients, unlike the two previous studies in which we're looking at outpatients who did not wind up in the hospital for the most part. And most of these were high income countries. So that may also distort what conclusions we draw. But what I wanted to point out again was that a bunch of different organ systems are at play. We saw, a quarter of the patients had difficulty concentrating. We see 1 in 7 patients have post-traumatic stress disorder. Oxygen use is reported by as much as 2/3 of the COVID survivors. But remember, this is mostly hospital COVID, so very sick COVID survivors. And functional impairment was seen in almost half of the patients. So again, the patients who have COVID, severe enough to put them in the hospital for the most part, wind up with pretty serious lingering complications, even beyond 6 months from their original COVID. Another important study that came out earlier this year was the COVID symptoms study. And this looked at how many patients were having persistent symptoms. And they found that, with a group of patients that were probably on the younger side, that only 2.3% of them were still reporting symptoms more than 12 weeks out from their COVID. But again, it really depends on which population you look at, exactly how many people have lingering complications. What this study did show is that people who had more symptoms during their COVID were more likely to have lingering complaints and long COVID. The older you were, the higher your body weight. The obese patients were more at risk for long COVID, and people of female sex seem to have a slightly higher risk. And those with greater than 5 symptoms during their first week of COVID were more likely to have persistent symptoms beyond 30 days. The best way to assess the prevalence of long COVID is to follow confirmed SARS-CoV-2 positive patients over time. So the UK Office of National Statistics has followed 20,000 patients since April 2020. And at 12 weeks, about 13.7% of them still had symptoms of some kind. So long COVID in this case meant any COVID symptoms lasting beyond the first 4 weeks, which is the same definition that the US CDC uses. And here's a graph showing that the rates of people still complaining of symptoms drops the longer you follow them. But disturbingly, you can see that it sort of plateaus out here at about 18 weeks, and it looks pretty flat. You may at that point still see some people drop out of the symptomatic group, but it looks like there's a persistent chunk of folks, maybe in the 10% range, who are at 6 months out or longer are still going to be complaining of lingering symptoms. The University College of London Hospital post-COVID clinic described their experience with patients. For those who were in the hospital with organ injury, about 2/3 of them are recovering well at a year out of this clinic operating, but a third shows slow improvement, especially in their chest symptoms. And they estimate that less than 10% of the critically sick COVID patients, meaning sick enough to be in the hospital, will have permanent heart or lung damage. On the other hand, the non-hospital milder COVIDs that come in with this long COVID chronic fatigue picture show slower improvement. They're in their 30s and 40s. They complain of fatigue, brain fog, muscle and joint pain, and sleep disturbance. And while 12 months out, half of them have left the long COVID clinic, another half of them are still coming in feeling crummy. A patient-led research collaborative also has suggested a bleaker picture for the recovery of long COVID, whereas at 6 months, the majority of them were still having fatigue and malaise and cognitive dysfunction, and about a third of them are having menstrual issues. But again, this is sort of a self-selected cohort, so it's giving us only a very specific picture within a group that is, has a bit of a bias in terms of who's in it. But they did describe kind of waves of onset of symptoms, starting with dry cough and fever right in the aftermath of their COVID, but then symptoms attributable to dysautonomias like heart palpitations or weird low blood pressure events at 2 months out. And then at 4 months out, they start describing the skin rash, the muscle pain, and the brain fog. So some of these things do show up months out from the infection. Interestingly enough, patients who had the original SARS infection back in 2003, some of them also had a long Sars syndrome that was described. In about 20% of them, a year out from their surviving SARS, many of them still had weakness, fatigue, muscle aches, and inability to work. And there was some suggestion that they were finding fragments of virus in their brain tissue, and that maybe persistence of viral infection in the brain was part of where they were getting their long SARS syndrome. Patients who survive Ebola infections, which is another serious viral infection that's frequently lethal, shows that the majority of survivors of Ebola continue to have a symptom affecting their quality of life, a long time out from surviving the actual acute infection. And patients also, again, harbor Ebola in immune reservoirs. In fact, there was a very famous case a year ago where someone who had survived Ebola many, many years during an outbreak in the past wound up infecting a sexual partner with active Ebola, and they had a new outbreak, which told us that that virus had lived latently in that person's body and had reactivated. So persistence of virus certainly is one way you could wind up explaining why people have long COVID, but we also consider maybe there's an autoimmunity phenomenon. Some people have postulated that there is a reactivation of herpes viruses like Epstein-Barr virus because of the way that SARS-CoV-2 blunts the interferon system, as I mentioned. There's some belief that maybe there's chronic inflammation of the brain tissue, which might explain why long COVID resembles chronic fatigue syndrome, which is another condition where we see neurological inflammation, and even the belief that maybe disturbances in the gut microbiome can explain some of the problems with these patients long term, which is possible since the COVID infection also affects the gut. One new piece of information that came out in September was a study in the Lancet Infectious Diseases, a journal which showed an update from the COVID symptom study, which again was the study where people self-reported symptoms using an app. And what they saw was that looking at almost 1 million patients in the UK who were fully vaccinated, first of all, only 0.2% of the fully vaccinated during the 6-month period developed a breakthrough COVID-19 infection. About 600 of them kept reporting symptoms out through at least a month. And of those, 5% had persistent symptoms at 4 weeks out from their original COVID infection. And the unvaccinated group in the previous reports, long COVID was reported in about 11% of the patients. So this implied that there was roughly a 50% reduction in long COVID presentations in those who had vaccination, which should be very reassuring to people who've been vaccinated. But I also think what gets undercounted here is how very few, it's just 0.2% of the fully vaccinated during the 6-month period develop breakthrough infections, which tells you that the protection of the vaccines, especially in the first 6 months after vaccination, is very strong. So that's one thing that we can take away. You're seeing less long COVID because you're just seeing less COVID whatsoever in these vaccinated patients. But when they do get breakthrough infections, their risk of long-term complications appears to be half as much as what we expected with natural infection in the unvaccinated. So the next steps will be to define care standards and pursue research integrated into direct patient care. Guidance from the CDC is forthcoming. The NIH has initiated a research initiative, which I'll mention in a moment. And Congress has provided over $1 billion to do research into post-COVID complications. And so this was announced last month. New York University is going to be a distribution center for $500 million in funds for the Recover Initiative, which is a cohort study that's actually a super cohort being organized by NYU and the Massachusetts General Hospital. And enrollment is hoping to follow between 30 and 40,000 people with post-COVID complications to help us better understand what's going on with their bodies and how to help them recover their health. And that's it for my presentation.
Wowza. Well, I think we've used up our time, but just to reassure anybody that has further thoughts or questions, you can send them to the Friends of the Bassett, Friends of the Village Library website, where they'll be fielded eventually, or you can go to the YouTube presentation. Thank you very much. And I think Leanne wants to say goodbye.
Thank you very much, Richard and Jeanette, for a great program. I mean, if you want to answer any additional questions, Jeanette, If you want to ask some questions, feel free. We've got a few minutes if you'd like to do that. It's your call.
I think are there any other viruses that have been so global in their attack on such hugely pervasive systems in the human body, like the Renin Angiotensin system, which is sort of like estrogen? It's everywhere.
Right.
Are there other viruses that are so global in their ability to attack everything that we have?
Well, the example I would give is, I think part of why I was so willing to believe that this was a multi-system infection was, first of all, the molecular mechanism made sense that would be true. And we started seeing reports of neurological problems in these SARS-CoV-2 survivors out of China in even the late spring of last year. But I think part of why I found that believable is, of course, I worked in the AIDS field, where HIV, thanks to destroying the immune system, wound up with every organ system being indirectly affected by that and damaged. So I think that's another example of a virus that winds up producing multi-system complications by obviously a different mechanism. There was a very interesting paper that came out about the Russian flu in 1890, which I think I referenced earlier. Originally, that was described as a flu. They thought it was an influenza virus. But when you actually look at the historical reports from physicians at the time, there was a report produced in the UK about the Russian flu, and they eerily described a lot of things that sound an awful lot like COVID-19, including that the children and adolescents were very much not affected by this influenza, whereas the elderly were disproportionately affected. They described loss of taste and smell from the infection, which, as we know, is kind of characteristic of this current coronavirus pandemic. And they also saw a host of intestinal and neurologic complications in the survivors of this influenza. So we now are thinking that perhaps the 1890 Russian flu was in fact the emergence of OC43, which is a beta coronavirus in the same virus family as SARS and SARS-CoV-2.
Wow.
Yeah.
I don't think there are any other questions that have not been answered by your talk. Thank you so much. It's
My
horrifying. But the question is, the reason why the older people are not so getting such bad long COVID because our immune systems are weaker? Could that be?
I don't think we really know. I think that's one of the things we'll have to study, of course.
Yeah.
One of the things I'm hoping to organize here at Bassett is a formal review of post-COVID complications. We're hoping to be part of a larger super cohort that's being organized internationally, and they want to add our health system to that analysis. So I'm hoping we'll get a chance to study that locally.
Okay, great. Thank you.
Well, thank you so much, Rick and Tanette, for just a terrific program today. And let me just do a quick little, So I'm going to share my screen just to tell you about some important dates this month and next month. And so give me a moment while I share my screen and let's see. Okay. So first on election dates, courtesy of the League of Women Voters of the Cooperstown area. Tomorrow, October 18, mailed, online, emailed, or faxed applications requesting to receive an absentee ballot must be received by the Otsego County Board of Elections. Then October 23 through 31, that's early voting, which takes place in person at the Otsego County Board of Elections in Cooperstown and the Foothills Performing Arts Center in Oneonta. Hours do vary by date, so check out otsegocounty.com to find out more. November 1 is the last day to apply in person for an absentee ballot at the Board of Elections. And then Tuesday, November 2, Election Day. Polls open 6 a.m. to 9 p.m. It's also the last day to postmark your absentee ballot or deliver it in person at the Board of Elections. And let me make just a quick backtrack to October 23. for a great opportunity to get rid of your unwanted confidential paperwork. The Village Library of Cooperstown is sponsoring a paper shredding event. From 10 a.m. to noon, a shredding truck will be stationed at the front of the library building on Main Street. Community members may bring as many as 5 boxes of material for shredding. And then, having cleaned your house of Halloween candy and paper and exercised your voting rights, please join us November 14, when the Sunday Speaker Series will present a program with Mark Ferrara, SUNY Oneonta English professor and author, who will speak on experimenting with intentional living in New York State. Professor Ferrara will take us inside several of the most interesting intentional communities in New York history that challenged capitalist economic arrangements to attain ideals of harmony, equality, and social justice. And the fall Sunday Speakers programs are scheduled for 3 p.m. via Zoom, and participants can register online at FOVL.eventbrite.com. The programs are free and open to the public. And if you have any questions or comments, including follow-up questions for Rick, please email FOVLfriends22main@gmail.com. All right, and then I just want to thank you again for joining us, and we look forward to seeing all of you soon. Bye-bye, everybody.